Hey everyone, today we're going to talk about utilizing the ECG to recognize STEMI and the more recently coined term OMI for occlusion MI. And so those are going to be patterns that don't present with the traditional STEMI criteria, but still manifest with the same underlying diseases, have the same mortality and time critical nature to them. So it's vitally important that we recognize those as soon as possible so that we can get them to definitive care. So what is a STEMI? When we see ST elevation, what does it mean pathologically? What's going on in the body? I'm hoping if you saw, this patient rolled into your ED or you responded in your ambulance and you saw this ECG pattern that you'd be able to recognize that this is an obvious STEMI. But what does that mean when we activate? What does those ECG changes represent? So we're going to talk a little bit about that because I think it's important because as we start differentiating our traditional STEMI criteria from your OMI criteria and what an OMI is and why it's important, it's imperative that we understand that underlying physiology and how we can better differentiate these patients and get them to where they need to go. So when we see specific patterns of ST elevation in a patient presenting with ACS-like symptoms, that's supposed to be a good indication that we're dealing with a acute occlusion of one of our three primary vessels, the right coronary artery, the left anterior descending artery, or the left circumflex, or one of their major branches. And in those patients, we recognize that that is a time-critical illness and that they have a very high short-term mortality. So identification and early therapy is a primary driver to improve their outcomes. So the goal of any STEMI program should be to identify these patients here, ones that have a transmural infarction pattern. It's not about just looking for ST elevation necessarily. ST elevation is supposed to predict this injury pattern. That's the goal, is to identify patients who have those complete occlusions because they develop into these injury patterns, and these patients have really high short-term in-hospital mortality, much higher than the classic, what we call an in-STEMI group. The problem arises is that our system is built and the entry into this time critical system requires certain ECG changes like ST elevation, and the issue there being that we know that there are patients that can have this injury pattern that don't manifest with your classic ST elevation, and so we need every possible way that we can try to identify these. Of course, we can use troponins, and we have high sensitivity troponins that can identify the acute MI very early, but if they have I'm using air quotations, normal ECG pattern where they don't meet STEMI criteria, that may result in the patient care being delayed while we do serial troponins, which can be Q2, 4, 6 hours. And so it's a long time to have a complete occlusion or near complete occlusion of your coronary vessel to get that entry into the system. So the goal should be to identify these patterns and cast the broadest net that we can while still maintaining a high level of sensitivity and specificity. So as we delve deeper into how to recognize these people, another problem that we can identify is, and this part is more an issue with the ECG in general, which is that all the ECG is showing you is a potential injury pattern. It's not necessarily showing you that you have a specific issue located within the coronary vessel. Now, your patient walks in with chest pain and you see ST elevation, your first thought is to presume that they have that MI type 1 that you see on the screen, right? A plaque rupture with thrombus. So you have a major occlusion of the vessel, and that's causing that specific injury pattern. The patient needs the immediate PCI intervention. The problem with that is that the ECG manifestation is just showing you a disruption in blood flow to a region, but there's lots of things that can cause it as well. So as with most things in medicine, nothing replaces our physical exam, history taking, and other diagnostics that we can use to help improve our diagnostic quality. But these are just some examples of things that would present with similar ECG findings that are not necessarily a candidate for PCI. So a good one is vasospasm or endothelial dysfunction. So patients with coronary vasospasms are not necessarily going to benefit or need PCI. If this is just, perhaps stimulant toxidrome where their coronary vessel has clamped down, they're going to present very similar because to the heart, it doesn't know whether it's a clot or a vasospasm. It just knows that the blood flow has been disrupted. And so if the patient's taken a bunch of stimulants, cocaine, methamphetamine, and their coronary artery occludes, they're going to have chest pain, they're going to have ST elevation, but it's not a PCI candidate necessarily. That's somebody that needs, perhaps will resolve with nitroglycerin and relaxation of that CNS stimulant. And there can be other issues like supply-demand imbalance. You can have patients who just have poor perfusion. A good example is post-cardiac arrest patients. The AHA now doesn't recommend doing a ECG for the first, I believe it's 8 minutes post-cardiac arrest because it's non-diagnostic, because the heart was in a terrible supply-demand mismatch. You can see ST elevation even in profound shock and extreme hemorrhage, multiple different instances. So on top of the things I'm going to talk about with an ECG before we even get into that, because we're going to talk about all kinds of different subtle things that we can look for, we can never abandon that physical exam. We can never abandon our clinical gestalt, and the patient has to match the ECG, not trying to, the ECG needs to match the patient, not trying to force a patient to match an ECG finding that we may see. Now, on that note, there's plenty of patients who present with abnormal presentation. So this isn't just chest pain. This is also, especially the three major groups I have listed up there, the elderly, the females, and diabetics can present oftentimes without chest pain. It's the elderly, especially after, I believe it's the age of 80, chest pain is not their primary symptom associated with a STEMI patient. And so we have to think about all the other things that can be involved in that, and making sure that we're doing a really good workup on our ACS patients to rule that out. For me, a good rule of thumb is any patient with symptoms that reside above the belly button typically end up getting an ECG. Certainly syncope patients or anyone that could potentially have that their symptoms could be of cardiac nature, 12 leads of ink and paper, it's an easy, quick test to rule that out and make sure we're doing our due diligence. So the next problem to kind of lay in here before we get into the ECGs itself is our traditional STEMI criteria have a relatively low sensitivity with much better sensitivity. So it depends on the literature, but you're looking at somewhere between 20 and 60% typically for your sensitivity. So if you have ST elevation and a patient with symptoms to correlate with, that's a pretty specific finding and often can be a good way to rule in STEMI. The problem arises when you have that patient who presents with ACS-like symptoms and you're very concerned that you may be dealing with that occlusive myocardial infarction, so a complete or near complete occlusion. If you do not have ST elevation, it's not overly sensitive and thus not a great rule out tool. And so kind of part of today, I'm going to talk a little bit about, as I said, expanding our net and learning some other ECG findings that will improve that sensitivity of that test and can help us make better decisions about who needs that PCI care, who needs that TCD activation. And this is where the occlusion myocardial infarction criteria is going to come into play. That's going to help improve both the sensitivity and specificity using the ECG. So a problem that's going to arise as we start expanding our net is that we've also built a system that is predicated on the need for ST elevation to gain entry into like a PCI activation. So, and this is especially true for pre-hospital providers who might be doing a field activation. So again, not here to be able to solve that problem in our system, but just to prepare you that what we can do is make a better case for our patients and try to get them the care that they need. And certainly, if nothing else, what it can do is help triage patients if you're working in a facility that doesn't have PCI capable facilities. If you're seeing some of these ECG patterns that we'll be talking about, and you're working in a facility or on an EMS unit that doesn't have that capability, it can help triage those patients so that we know how to prioritize and where to get them. It's not that it may not even be that important that we're activating as much in that patient group as it is just getting them to those facilities and doing serial ECGs, looking for changes, and when they reach that critical threshold, then we can get activation versus just chalking it up as a air quotations normal ECG and letting them sit at the wrong place or taking them to the wrong place, which of course would worsen mortality and the outcomes for our patients. So the other thing I'd like to talk today, and we're going to go over, is just some things that can have ST elevation that end up not being an MI. And if you've worked any period of time in the ED or in pre-hospital work, and you've probably had a patient presenting with chest pain, done an ECG, saw some ST elevation that you thought was a STEMI, then activated, did the whole shebang, and then the patient ends up not being any ketomide. PCI was either negative, or the PCI facility calls you and tells you you're wrong, it's not that. And so I'm going to talk about some of the mimickers, especially the first three, your left bundles, your V-paste, and LVH patients, and how to differentiate, because they all have inherent anteroseptal elevation built into them. So how do we differentiate those? And we'll discuss some like the benign early repole and pericarditis, where they may have ST elevation, but the shape of the ST segment and there's and various changes in that ECG that can help us identify that. And of course, with some of them or most of them, your physical exam and other diagnostics can help clue you in. Case in point being like the Takotsubo's cardiomyopathy or Brugada syndrome, anemia and shock. If your patient's bleeding to death and shows ST elevation, it's probably not a STEMI, it's probably hemorrhage. So we'll kind of intertwine those throughout this lecture as we try to improve our ability to use that ECG to diagnose. So probably the most important slide on here is going to be this checklist. So this is just everything listed in one slide that we're going to look for to identify the OMI or STEMI. So the patient that may be manifesting with a transmural infarction pattern. Again, my caveat, they can have all these things, and there are certain mimickers that from an ECG standpoint, there is no way to discern. Again, the coronary vasospasm is always a good option, or you may have like a type A aneurysm that back dissects through a coronary artery. Both of those diseases, they're going to present identical to STEMI on ECG, but they are different. It's either that in the first example, it was that the coronary vessels spasm shut and obstructed blood flow, and in the second example of the back dissection, it's essentially a hemorrhagic STEMI, kind of like how we have ischemic and hemorrhagic strokes. It's a rupture of the coronary artery that's disrupting blood flow, which will absolutely present with a ECG pattern identical to the thrombus, because the ECG doesn't know any better, the heart doesn't know any better. It just knows that the blood flow is interrupted and not coming there. So those you're not going to be able to identify through your ECG. You'll have to identify those through your physical exam and diagnostics. But there are some that we can use this checklist to help weed out and improve our net to catch these patients. So we're going to talk about localized ST elevation and its reciprocal changes. The shape of the ST segment is an important marker. Is it convex or straight versus concave? Upward concave ST elevation is often not indicative of the occlusive MI or STEMI, and is much more predictive of things like pericarditis, whereas a convex or straightened ST segment is concerning. Are there pathological Q waves? Do I have hyperacute T waves? We'll talk about some STEMI equivalents like De Winter's T waves and Wellenstein, and as well as Scarbosa, and then do I have evolving changes? And out of everything on this list, and I do truly use it as a checklist, the more boxes I can check off of this, the more predictive, the more sensitive and specific that ECG is to the transmural infarction pattern or that injury pattern that we are trying to identify, and the evolving changes. So taking all those things in that list, and the more of those boxes that are manifesting before your eyes, the more likely it is, right? Well, because the hallmark of the acute myocardial infarction is the acuity. It's the sudden onset. And so when you have maybe some questionable T waves and some interesting ST shapes, and you see those manifesting, and more of this checkbox is manifesting in front of you, the more likely you're dealing with that transmural pattern, and the more likely we need to get that patient to definitive care. I pretty much can't ever talk about ECGs without talking about kind of this fundamental rule. As I do a lot of ECG education, I go around and it just surprises me how many people don't know where these leads look. So the whole point of the ECG is to look at the heart from various angles to identify these local injury patterns. And so to do that, you really have to have an idea of where these leads look. So anytime you're doing a 12-lead ECG, you're essentially getting two ECGs. You're getting a hexaxial ECG, which looks at the heart from a vertical plane. That's your limb leads. And so you have leads 1, 2, 3, plus your augmented leads, AVL, AVF, AVR, and then you have your precordial leads. They look at the heart from a completely different plane. They look horizontally. They're easy. Wherever you put those stickers, they're looking essentially directly back. And so from V1 to V6, I've kind of got it displayed out on your screen there so that you can kind of understand. This is going to come back up and is super important when we start talking about identifying a localized injury pattern and then identifying those reciprocal changes. If you don't know where those leads are looking at on the heart, then that's going to make everything a lot more complicated. So this is definitely something to kind of commit to memory so that you know, so when you're looking while this is on your screen, just to give you a good example, if you're seeing some changes in lead 3 that are concerning to you, the lead you want to look at is lead ABL for reciprocation because it has that highest angle of reciprocal view compared to lead 3, and vice versa. If you saw changes in ABL, you'd be looking at 3. And so we'll revisit this as we go, but this is an important thing to commit to memory and to master, is where all these leads look. It also is worth your time invested, because when we start talking about other ECG changes as you want to grow and develop your ECG identification skills, this is paramount to and is the foundation to all of that, whether we're trying to identify right ventricular strain patterns or LVH or left bundles or on and on and on, all those subtle ECG patterns. Hypertrophic obstructive cardiomyopathy is another one. It'll make a whole lot more sense if you can just kind of commit this to memory. So let's start going through the checklist. So we'll start with ST elevation. I think most people do pretty good with this. Our classic criteria is 1 millimeter or greater in most leads. It does change depending on the age, gender, and location of those leads. Most of your ECG algorithms are pretty good at identifying that, as long as you're putting the correct age and gender into your patient. So that's kind of done for you. But where we do struggle a little bit is where to look for, or how to measure, I should say, ST elevation itself. So it's identifying the baseline. A lot of people like to use the PR segment, and the problem with that is PR segment, it does not represent the isoelectric line. You can have PR depression. You actually can have PR depression in one of the common STEMI mimickers, which is pericarditis. And so if you are measuring your ST segment from the PR segment, you're going to get PR, and there is PR depression present that can feign this. This can trick you into thinking that you have ST elevation when in reality you do not. So where you want to measure it is from that TP segment. And so I'm going to pull up my little pen line here. So you want to measure from right here and measure backwards. When you are measuring, you do not want to measure from here, because again, you can have PR depression or you can have PR elevation, which would nullify your measurement, especially when you're looking at the ECG and you're trying to find subtle changes, which is what's going to happen early. The only other thing with ST elevation that I like to stress is that while 1 millimeter criteria is pretty good, it starts to fall short when you have QRS complexes that are less than 5 millimeters. When they look at ST elevation, it's more predictive as a ratio. And when you start really delving into ECG criteria in general, most of the accurate criteria tend to have some sort of ratio built into it, because when you're comparing, say, the T wave to the QRS complex, they're two events of the same organ. So the T wave is your repolarization, QRS is depolarization. So there should be a relationship among all these things. And so if you have, in reality, ST elevation is more accurate at 20% the height of the QRS. And so if you have a really tiny QRS, and in this case 5 millimeters or less than 1 box, then 1 millimeter may fall short. When you look at missed STEMIs, one of the things that come up often are STEMIs that occur in regions where the QRS is smaller. And something else to think about is, in the region that is actively dying on you, the QRS is the ventricular depolarization, and that depolarization is cellular activity, right? That's electrolyte flows. And so as those cells start to die and they stop producing as much energy, the QRS can shrink. So it's not uncommon to see QRS complexes that are quite tiny in the region that's affected, which is problematic if you're waiting on 1 millimeter criteria, because you're going to have patients that may have clinically predictive ST elevation, but it doesn't hit that 1 millimeter criteria. How do I improve that? By adding all these other things on the list that we're going to talk about. That's going to improve that sensitivity and specificity. Next thing on our checklist is to use the ST segment itself. This is an important warning sign as well. It's a pretty sensitive and specific evaluation, especially if your QRS and QRS and T wave are concordant, meaning on the same side, either both up or both down. But straight or convex ST shapes are problematic and more predictive of the acute MI compared to the concave. So the classic teaching is, do I have a smiley face or a frowny face, as you can kind of see on your screen there. So happy face ST elevation is more predictive of pericarditis, benign early repol, or some of the mimickers, especially if it's coupled with an Osborne wave, whereas straightened or convex ST shapes are much more concerning. Another interesting tidbit for the ST shape is that it will often change before the ST segment elevates, making it an early sign. This can catch your attention. And again, if you're that pre-hospital provider or rural ED provider and you're worried about this patient, you see that, while you may not be that may not be enough as a standalone to activate STEMI, it may be enough to make you recognize this is a dangerous patient. I need to watch them closely. I need to get them to the right place. And then you start doing your repeat ECGs. You start using that checklist, and that's how we get patients more accurately identified and get them to the right place. The straightened segment that you see here, this one here, this is called the check mark sign, where the J point kind of makes a little check mark. So that, again, is very predictive, very concerning for that acute MI, even in the absence of ST elevation. Again, may not be able to activate, may be able to point you in the right direction and get that patient where they need to go. So here's just a real life example. If we scan over this and we look at it, we start adding in some of the things we're looking at. We notice, hopefully you can appreciate over in leads 3 and AVF and lead 2, I have some clinically significant ST elevation. If I look, I also have that check mark sign, right? So some straightened ST segments. And then confirm the diagnosis, I want reciprocal changes. And if you remember back when I said we're looking at lead 3 here, the lead that looks the most opposite to that is AVL. So lead 3 looks from the patient's right lower quadrant. So if I think about coming from like the right hip bone, that angle or vector, AVL stands for augmented vector left. So common sense, it comes over the kind of the left shoulder of the patient. This presentation that you see in AVL is very concerning as a standalone. So imagine we don't have ST elevation in leads 3 and AVF yet. Maybe we got these straightened ST segments and we got some concerning signs in a patient that fits. But what you see here that's concerning is you see this flipped T wave in AVL, and it's not just that it's flipped, but it's how it's flipped. You have this down sloping of the ST segment. It's very straight. You can actually see at the terminal end, it's still a little upright, and it is not present in lead 1, as you can see. So in isolated T wave inversion with that morphology in lead AVL is typically the first ECG change that you see in the early inferior MI. Again, if I only have a flipped T wave in AVL that isn't present in 1, is that enough to necessarily activate STEMI? No, but it's definitely somebody that probably needs an aggressive cardiac workup. We need to watch them. We need serial ECGs, and we need to consider getting them to a PCI capable facility before we manifest. Again, that you save that presentation in the back of your brain for 6 months from now, 3 o'clock in the morning, and that might just save a person's life. So more examples on that ST shape. So here we have ST elevation all over the place. It's present in leads V2, V3, V4, V5, V6, leads 1, AVL. If you measure it wrong, you might think you have ST elevation in 2. Again, you don't if you measure it correctly. The PR segment is just depressed. So this is pericarditis. If you think about your differential, this patient either has a massive global STEMI or it's something else. Now, problem pericarditis, it's certainly going to present with some chest discomfort of some kind. Yes, the physical exam will most likely be different, probably a recent history of viral illness. You can have positional chest pain, things of that nature, but the ECG right off the bat can clue us in. So that diffuse happy face ST elevation should cause us to pump the brakes and just ask a couple more questions and make sure that it is truly that STEMI patient versus something else, which in this case it is. It turns out to be just a case of pericarditis. And benign early repull is very similar. There's a lot of overlap in the ECG presentation. Most of their concave ST elevation occurs in the anterolateral leads, like you can see here. You have some fairly prevalent ST elevation V3, V4, V5, V6. It's happy face. You can see that notching pattern present here in V4. I zoom in on it here on the next slide, so I don't want to focus too much on it, but that's that Osborne wave. We're mostly taught that Osborne waves manifest during hypothermia, but they can present in both benign early repull and pericarditis, as well as hypercalcemia, but they are not specific to just hypothermia. Also, if you're using the ECG to diagnose hypothermia, there's this wonderful diagnostic called a thermometer, which probably help you a lot more. So there's that zoomed in Osborne wave. Looks like kind of like an upside down J or fishhook. It's sometimes just called a J wave. Again, if you see that going into ST elevation, it doesn't completely rule out that you have that transmural injury pattern, but it's much, much, much less likely, and you are much more likely to be dealing with pericarditis or BER. So we want to take a moment, do some more investigation, and see if that's truly what we're dealing with. So far we talked about ST elevation, we talked about ST shape. Now we're going to add in hyperacute T waves. And so this is another great ECG tool because it happens early. The ST elevation typically doesn't start to manifest until around 30 minutes to 2 hours after onset of the occlusion. Hyperacute T waves along with ST shapes are kind of those first warning signs. So again, there are some T wave changes that are activatable. We'll talk about that in a little bit, but most of the time hyperacute T waves are just going to warn us that we might be dealing with that occlusive MI and that we need to get them to the right spot. So if we think about what a T wave should look like, the ascending limb should be shallow and then the descending limb should be quite sharp. They should not be symmetric, and they usually should not be greater than half the height of the QRS. Some evidence suggests that a QRS, the definition of a hyperacute T wave is if it exceeds 75% the height of the QRS. But certainly, if you're looking at a T wave that's the same height as the QRS, again, thinking about it as a ratio, not thinking about it as overall size, but about the ratio compared to the preceding QRS, that can be predictive of the hyperacute T waves. So if you look here, we have a good example of hyperacute T waves. These are fairly obvious, big, tall T waves. They're symmetric in nature. These specifically would sometimes get called rocket ship T waves. They look like a space shuttle silhouette on the launch pad. And if you compare them to the QRS complexes that precede them, they're quite large, quite obvious. So these would be an early warning sign of the presence of a acute MI. Okay, so let's take a look at this ECG here. So if you scan across, let's assume your patient is a 50-year-old male presenting with ACS symptoms. You look and we see what hopefully you notice are some tall symmetric hyperacute T waves located in the anterolateral region. And there's a extra finding in here, which is alongside these hyperacute T waves, is some anterolateral ST depression. So this is a very specific and concerning sign. This is something called De Winter's T waves. And so this is a very early left anterior descending occlusion. So this is a STEMI equivalent essentially. So the hallmark is the anterolateral ST depression with hyperacute T waves. Those two findings together are very sensitive and specific for that early anterolateral STEMI. It's not a STEMI because it doesn't have ST elevation, but if you were to do serial ECGs on this patient, that region, you're going to start to see those ST segments go from being depressed, they're going to start to elevate until you hit that classic anterior pattern. So another issue with hyperacute T waves is if they're big and tall and symmetric, like you've seen in some of those previous slides, you notice, okay, those are obvious. They jump out at me, right? That's easy. You probably already knew that. But remember, it's a ratio compared to that preceding QRS. So if you look here, this is another case. This patient was a middle-aged male patient with chest pain and looked the part, pale, diaphoretic, very ill-appearing. But the ECG kind of came out a little benign, again, or benign appearing. Hopefully you can appreciate a couple subtle things. First off, noticing that the QRS complexes are fairly small in most leads. In this case, the patient was quite large, and so patients with big chests or a lot of body habitus, since those electrical signals have to travel a further distance, that can cause impedance and can cause impairment of the reduction in the height of the QRS and T waves and corresponding ECG. There's other things that can cause that as well, but in this particular case, that was the issue. So the providers took the ECG, they saw this, and thankfully they caught the warning sign and triage this patient appropriately to a PCI facility. If you look, using that rule, right? So the T wave should correspond with the preceding ECG. A good example of a more normal T wave, if you look at lead 1, in lead 1's case, you've got a T wave that's less than 50% the height of the QRS. It's got this nice gradual ascending limb. It is a little symmetric looking, but overall fairly normal, benign looking T wave. But if you come over here, we see some problems, right? So not only is our T wave bigger than our QRS complex, but we're also getting that straightened ST segment. If we look up here, we're getting more of the same. And so this could be an early warning sign, and especially in this patient presentation, is very concerning for acute early OMI or STEMI. This patient did go on to have 100% LAD occlusion. This was that initial ECG. So as I was talking about, the De Winter's T waves are the joining of hyperacute T waves along with that ST depression. So here's another pattern here. If you look, you can see you have those tall symmetric T waves in the anterolateral region with the corresponding ST depression in that region. Like I said, this is an early presentation, so this is an early complete LAD occlusion. If we were to do serials on this patient, eventually those ST segments would start to elevate and look like that classic STEMI patient. And one final example here just to drive it home. So another ECG case, we look at it, we see tall symmetric T waves in the anterolateral region with corresponding ST depression. So another example of those De Winter T waves in a real ECG case. So moving on down our checklist, we've talked about ST elevation, we've talked about ST shape, we've talked about hyperacute T waves, adding in De Winter's T waves as a subset, and now we have our pathological Q waves. So out of all the ECG criteria, this is a very specific and sensitive test for a myocardial infarction. The problem being that once the Q waves form, they often persist. So in this case I'm showing you here, it's pretty obvious because along with the Q waves you see ST elevation and reciprocal changes, etc. But where you can use Q waves is by repeat ECGs. So imagine we took an ECG and we look at this inferior region and we don't have any of this ST elevation or depression, but we have this little Q wave in AVF. And then say 20 minutes later I look at that Q wave and now it's doubled in size. Well, that can't be a old finding, that's going to be a new finding. So what are the criteria for pathologic? Because there are other things that cause Q waves. Q waves is just a name for the first negative deflection here preceding an R wave, but if that is 1 millimeter wide and 2 millimeters deep, those are the criteria for pathologic. As they've studied them more, they've realized, hey, just like everything else, maybe we shouldn't be using overall absolute measurements and instead should be using a ratio to the R wave that follows it. And so if you have a Q wave that's 25% the overall depth, or I'm sorry, 25% the overall height of the proceeding R wave, that's predictive. It doesn't need to be one box wide as well. That's really important that they are wide. There are things like hypertrophic obstructive cardiomyopathy that will cause deep Q waves in the inferior leads. However, they tend to be very narrow, whereas the pathological Q wave of a MI tends to be, like I said, at least one box wide, if not wider. Here's just another inferior example. So we have those deep Q waves present here, a little bit less in AVF, and almost completely gone by the time we get to lead 2. On top of that, if we use our checklist, we also see that beautiful check mark sign that we see there. These would qualify as hyperacute T waves as well. And then we have our corresponding ST depression with reciprocal change. Notice that downsloped ST segment, like I talked about earlier, with the terminal part of the T wave being upright. Almost kind of mimics what you would expect to see in hypokalemia, but again, it's localized to AVL and is not present in 1. Those are all highly predictive of the inferior STEMI pattern, which is usually predictive of a right coronary artery occlusion. So the reciprocal changes, one of the more important things we want to look for and can confuse people if you don't remember that map that I had talked about earlier where we know what we're looking at. So reciprocal is just a fancy word for opposite, and it refers to ST depression or T wave inversion in the leads looking from the opposite or near opposite angle to the one showing ST elevation. And so in that first example, the lead 3, the reciprocal would be AVL and vice versa. So a couple things on that though. We're all taught that there should almost always be a reciprocal change, but just remember in an anterior MI, anterior just means front. So if I have a anterior STEMI, the true reciprocal is in the posterior. If you don't do a posterior, you won't necessarily see the reciprocal change unless it's quite extensive or in a specific region where you can get an inferior vector. So if you see ST changes, ST elevation or any of your checklist items in the anteroseptal or anterolateral region, The best thing to do for looking at reciprocals would be to glance down at the inferior and see if I see T wave inversion with or without ST depression. If you want, you could also put some leads on the back and look for reciprocal changes, but it kind of depends on how obvious of the MI we're dealing with in the clinical presentation, whether I think that's worthwhile to you or not. So let's look at some examples here. So in this case, we have ST elevation along with a bunch of other things in the high lateral leads. So this is leads 1 in ABL. We have the check mark sign. We have ST depression. We have some hyper-QT waves, especially in 1. When we look down, right ABL, the opposite to ABL is lead 3. And so we have that ST depression. So what would that look like overlaid on our map? Let's take a look here. So all I've done here is I've taken that preceding ECG and I just split it across the hexaxial lead to show you what they look at. So if we look over here, we see ABL has the ST elevation along with 1. So we're thinking we have a transmural injury pattern on that high lateral wall. That's why these are called high lateral leads. And I look over here and I have that reciprocal depression. By the time I progress all the way over to lead 2, lead 2's vector is perpendicular to the injury and reciprocal changes, and so your ST segment ends up being essentially isoelectric, which is kind of classic for that high lateral pattern. So in this one, we have a classic inferior. We have all the things. We have the check mark sign. We have ST elevation. We have Q waves. We have reciprocal changes, hyper-QT waves. The whole checklist is here, and this is a fairly obvious inferior injury pattern. If I splice it out into our corresponding viewpoints, I look, and so these are where all these leads look, right? So 3, ABF, and 2 are inferior because they look at the bottom, and so my worst lead here is lead 3. This is a kind of a diffuse inferior transmural pattern with the reciprocal change in lead ABL as well. And so here we've got now talking reciprocals and anterior MIs. So this is a cross-section of the thorax with the heart. You can see the heart tends to rest against the anterior wall of the chest, which is why the precordial leads, the QRS complexes, tend to be quite large compared to, say, your hexaxial leads. Also, if you've ever done a posterior ECG, you might have noted, or a right-sided, which would sit over around here. You've probably noticed your QRS complexes tend to be quite small, and that's because that energy has a further distance to travel and has all this lung medium that's causing impedance and reducing that signal. So if I put these leads on and I see ST elevation in this region here, the true reciprocal would be on the back, which you're not going to see unless you put those posterior leads on. Again, I'm not necessarily advocating for that. I'm just pointing out that if you have an obvious anterior STEMI, but you're hesitating because you don't see reciprocals, you may not see reciprocals because you're not a standard 12 lead doesn't look in the correct region for that. So that's quite a checklist we have going, right? We talked about ST elevation, reciprocal changes, hyper-QT waves, ST shape, Q waves, STEMI mimickers, evolving changes, all those things. And so it can seem overwhelming to the novice provider, especially to keep track of all those things. But the good news is that it's all about recognizing patterns. And so there's really only 4 major patterns to identify because we have 3 coronary vessels that perfuse our myocardium. We have our LAD, our LCX, and our RCA. And then those are our 3 primaries, right? The LAD gets the anteroseptal region, the LCX traditionally gets the lateral region, and the RCA typically it's the inferior. If you've been doing this a little while, you're probably going, well, I've had patients that definitely had, say, low lateral ST elevation, but it was an LAD occlusion, and absolutely not everybody's arterial perfusion pattern is the same. The RCA is probably the most predictable, with about 90% of the population having the inferior wall perfused by the RCA, but again, everybody's different. And then there are branches and collateral perfusion. This is just a good rule of thumb. I shamelessly stole this off the internet. I just thought it was a good kind of visual representation to kind of correlate anatomical region with the leads that are looking at that. So we take that checklist, and then if we really want to move our ECG diagnostic to the next level, we want to plug it into injury patterns. And so the inferior pattern typically involves ST elevation, and all those changes, right, everything I listed, are going to occur in leads 3, ABF, and 2, with classically leads 3 and ABF being the worst. It is much less likely that lead 2 will be the worst presenting lead when you're dealing with the acute MI based on the normal blood flow patterns in the heart. So we're looking for, so if I see changes in leads 3 and ABF and possibly 2 that are concerning, my eyes go straight to lead AVL, and I'm looking for that flip T wave plus or minus ST depression, which is what you see here. If those changes are worse in AVL than they are in 1, that's even more concerning and more predictive of the transmural injury pattern. There are lots of things that flip the T wave in AVL, but they all usually flip the T wave to an equal amount in lead 1. So when AVL looks worse than 1, that's very specific for the transmural inferior pattern. And remember, it's the first ECG change that you will see. If I have an inferior pattern, I typically do a right-sided ECG as well. So I take leads V1, V2, V3 off the chest, and I put them where I would put leads V3, V4, and V5 on the right side of the chest. And that makes them RV3, RV4, and RV5. The reason I do that, when they studied right-sided chest leads to identify which ones are the most specific to identify right ventricular infarction, RV4 was the most sensitive, so I put RV4 on there, and then I put a lead on either side. Some people were trained to just take V4 and move it to the opposing side on the right side of the chest. Totally fine, that's great. We've already done our standard 12 lead. Why would I leave V1 and V2 on? I might as well just pull them off and move them all over there. That also leaves V4, V5, V6 if I wanted to be able to transition to a posterior and complete what's called like an 18 lead ECG. There's lots of debates about the use of nitrates if you have confirmed RV infarction. We could spend 2 hours discussing it. The evidence is pretty weak. I just always caution people, since that's also the AHA recommendation, that if you do have right ventricular involvement, that we're not giving large boluses, especially in patients that don't have a pre-existing high blood pressure, because there are case reports and studies that show that you can get some precipitous drops in blood pressure in that group. Again, the evidence is pretty mixed and it's quite debated, so I'm not going to waste too much time talking about it. Just something to think about as you're treating your patients. So here's that inferior pattern here. If we apply our whole checklist, we've got the check mark sign, we have hyperacute T waves, we have, so again, that straightened ST shape, we have ST elevation that meets criteria, and the reciprocal change. All of these things are occurring in a specific injury pattern. So we can look at this and go, that meets the criteria for an injury pattern. If I had ST elevation in lead 2 and lead AVR and lead V3, that doesn't make any sense because those leads are not anatomically contiguous. They're not looking at the same region in the heart. So that makes us very likely to be a complete or near complete occlusion of the RCA. So for me, I would go ahead and pull a couple leads off. I would throw that few leads on the right side of the chest just to see if I also have RV involvement, and that may or may not dictate how I care for the patient to some degree. For the anterior pattern, this is super simple. People flip it. A lot of people are taught in school to differentiate septal from anterior. I don't. They're all the same region. Just call it anterior, anteroseptal, and people often overcomplicate this. The anterior is just the front of the chest. So those are the leads that you put on the front of the chest, that they look at that spot. So where I put leads V1, V2, V3, they go right on the front. They're looking at the front of the heart. Those are the ones that are going to identify my anterior. So if I apply my checklist over here, I've got hyperacute T waves for sure. There's those rocket ship T waves. I've got some ST elevation in leads V1, V2, and I have some poor ST shape, as well as some potential Q waves manifesting as well. So this is, and if I look down here, you're getting, since this is kind of a higher up anterior STEMI, I'm getting the reciprocal changes in leads 2, 3, and ABF as well. So this is an LAD occlusion. They can often develop tachycardia as part of their response, as opposed to the inferior patterns, which often elicit a vagal response and can get bradycardia. However, anterior patterns do get the AV node in certain patients, so you can get some high degree blocks as well. So they can have kind of a myriad of presentations. With any cardiogenic shock patient, if they're hypertensive, we want to make sure we reduce that after load so we're not increasing myocardial oxygen demand. So this is a great opportunity for some nitroglycerin if they have the blood pressure to tolerate to reduce that afterload. And here's just another example. We have ST elevation in leads V2, V3, V4, and V5. We have like an ectopic beat, which is also showing concerning signs for STEMI. We have the straightened ST shapes, hyperacute T waves. We have obvious Q waves as well, extending out. And then in V5, this is a good example of what I was talking about, where your QRS complexes can shrink in size and become dominated by that T wave. This is actually called the shark fin presentation, not to be confused with shark finning in a capnogram, which indicates like bronchospasms. This is shark finning on the ECG, which is an ominous sign of an acute MI patient. So this would be a LAD occlusion. So we've talked inferior, we've talked lateral. Last of our standards is called a lateral pattern. Here, if we look, this is a high lateral pattern. This is the most commonly missed on a standard 12 lead, often because that is attributed to the fact that leads 1 and AVL tend to have vectors that are perpendicular to the depolarization wave, which causes the QRS complex to often be less than 5 millimeters, making that 1 millimeter criteria less diagnostic in this group. And here it's pretty obvious, though. We've got obvious ST elevation, we have hyperacute T waves, we have the straightened ST segments, we have the beginnings of Q waves, and if I look, the opposite to AVL is lead 3, and I have the ST depression as well. So this is a slam dunk high lateral pattern. Most likely culprit vessel in this case is LCX, although again, everybody's perfusion pattern is a little different. So when we're talking about the isolated posterior, this occurs in around 3 to 5% of patients. There is no ST elevation in the standard 12 lead. The most common warning sign, again, it's a posterior STEMI, so what you will see is the shadow of it. You will see the reciprocal, and the posterior is a fancy word for back, so you're going to see, if you have ST elevation on the back, you're going to have ST depression in the front. So any isolated ST depression in V1, V2, V3, and or V4, it's a good indication that you should probably put some leads on the back and rule out. Could it be subendocardial ischemia? Yep, and especially if that ST depression extends out to V5 and V6, so those low lateral leads, it's even less likely to be a posterior STEMI and more likely to be subendocardial ischemia, but it is worthwhile. It's some ink and paper, throw some leads on the back and see if you have ST elevation or any of those other things that we discussed about the OMI, right? So the ST shapes, T waves, Q waves, etc. If you have those things, you put some leads on the back, you have ST depression in the front, you have a patient that has the right physical exam presentation findings, you put some leads on the back, you see some ST elevation, bam, you caught yourself a posterior STEMI, and we can get that patient where they need to go and potentially save their life. There are some PCI facilities that will just allow you to activate on the anterior depression because of that concern for the isolated posterior. But we can improve that diagnostic by just putting some leads on the back. Yes, you can run tropes, but like we said, maybe if you catch it early, the trope isn't elevated very much, and then it's going to prompt the facility to want to do serial tropes, which can just delay their care. It's real easy. 5 seconds, I can put some leads on the back and take a look and see. You just stay in that fifth intercostal space, just like you put V4, V5, V6. You just extend those out on the back in the fifth intercostal space, ending at the paraspinous region, and you're there. And there's a visual exam. I also like this to show, if you look, so this is just a cross section, right? So this is V1 through V6. Really, we get about 150 degrees in the anterior surface of the heart. We don't get any of this part. So if I see ST depression manifesting here, I can throw some leads on the back, and I might get that ST elevation, that the infarction that's occurring here. And the same thing over here. We do get part of the right ventricle in a standard 12, but we just typically don't get that posterior part of the right ventricle. And so the big key one to look for is V4. So for me, I'll do an 18 lead. I'll take 1, 2, and 3 off. I'll shift them here, here, and here. And then for 4, 5, and 6, I'll take them off and I'll shift them here, here, and here. And I'll hit acquire. If I do it that way, the reason I like it is that the first column of your precordial leads now become your right-sided ECG, and the second column becomes your posterior. It's just easy. You can just write on it then and label it, and it's done, and most people should be able to interpret and understand what you're talking about. So here's a good example. We look at this ECG. Let's say they have a good classic ACS presentation, and we see a problem. We have ST depression in lead V2 and lead V3. So this patient went on to have a occlusion of their posterior descending artery, which is a major branch of the RCA. About 30 to 40% of inferior STEMIs have right ventricular involvement, and about 40% of, about 60% of posterior cases involve the right coronary artery as well. So it's a big player in a lot of different parts of the heart. The other 40% are typically the LCX that get the posterior wall. I think this patient actually, now that I think about it, I think this patient actually was an LCX occlusion on their outcome. Here's another example. This was the patient that had a corresponding RCA occlusion. So this was a sick patient presented in cardiogenic shock. They're also in a third-degree heart block, which should already tell you you're dealing with some sort of cardiogenic issue. And if we look here, this is a PVC, and we'll talk a little bit about how to identify it even in PVC, but you can see that ST depression there. And if you look at your underlying rhythm, we have ST depression here and here. So this patient also had some other signs. So if we look, we kind of scour over, nowhere in here do we really meet STEMI criteria, but remember, we're suspicious of posterior. And just to close out the case, they did do a posterior and it was positive. It had ST elevation on the posterior. But if you look over even on the initial, if we remember, the posterior is often perfused, right, about 60% of the time by the RCA, which also gets the inferior. If we look over, we see some warning signs here for early inferior MI as well. So we have a flipped T wave in AVL with some mild ST depression that isn't present in lead 1. We see the beginnings of a Q wave, some straightening of the ST segment. And so as this case progressed, the patient eventually required pacing, which is going to obscure your ECG at that point because they're getting transcutaneous pacing. But was able to get to the PCI facility, successfully cathed, had 100% RCA occlusion. And the last part, if I can stress anything, it's that you don't have to take one picture, right? So any ECG is just a snapshot in time. So if there's any doubt at all, if it's not an overtly obvious ECG, we can do serial ECGs and look for acute changes, which can cinch the diagnosis. So I have a couple cases to demonstrate this. So you've already seen this ECG. I was talking about this with hyperacute T wave. So this was a patient who presented with chest pain, classic symptoms, but it really looked very ill. But ECG, like I said, wasn't overly obvious. It just wasn't, it didn't match the patient quite. But the providers took repeats, thankfully. And so if we scour this real quick and we look, we can see this is the patient that has the hyperacute T waves in V2 with the check mark sign, maybe a little bit something in V1. Again, could be nothing, could be something. Definitely caught their eye because they were concerned based on the patient presentation. You'll also notice that because we're worried about anteroseptal, we look down at the inferior and we see these flipped T waves down here in 2-3 and AVF, so certainly concerning. So right off the bat, what does this tell us? Well, it tells us we should probably triage this patient to a PCI-capable facility, and then we do our aggressive cardiac care, right? We give our antiplatelet medications, manage their pain, manage their vital signs, and get them where they need to go. And so this crew initiated that, and then did repeats. And in 12 minutes, it becomes quite obvious what we're dealing with here, right? So now we have quite a chaotic ECG. It's hard to even quite tease out. We have bigeminal, sometimes trigeminal PVCs. We have obvious ST elevation, all of these things. Now, this happened in 12 minutes, so that made that decision easy, but sometimes this can take, again, 30 minutes to 2 hours to manifest. And so if we can get them going to the right place, they can be sitting at the PCI capable facility, maybe even getting prep for the cath lab when they finally fully pop that ST elevation. So let's look at another example. This is a much more subtle case. So this patient was a middle-aged patient presenting with not really overly concerning symptoms, kind of a benign presentation, but no history, healthy, took care of themselves. We look and we see this ECG and we start applying the checklist. and we look, and hopefully you can appreciate, if you look real close at lead 3, we've got, if I put 2 dots right there, we got that frowny face ST shape. We also have these negative Q waves, which again are not pathologic yet, but are certainly concerning, especially when you compare it to how small the QRS complex is. So I see some really subtle changes in 3. Well, if I'm worried about inferior, I should look up at AVL. And if I look up at AVL and I measure, I've got some very subtle ST depression with that downslope, and that the terminal end of that T wave is up. Again, the reason you're seeing that is because you're seeing acute T wave inversion happening in front of you. And so the T wave, when the patient was healthy, was most likely normal looking and completely upright, and now we're getting a little bit of the sagging in the ST shape. Again, is this enough? Probably not, but should they sit somewhere that, should they sit somewhere that can't handle STEMI? Probably not. This is certainly enough to get us motivated to get them where they needed to go. So this patient was transported to a PCI capable facility, and serial ECGs were done. If you look, I want you to focus really hard on lead 3. You advance this, and you see in lead 3 now that Q wave has deepened dramatically over the course of 20 minutes. That's the acute change that can cinch the diagnosis that we're dealing with that occlusion MI. Patient had 100% RCA occlusion. They never developed our ST elevation in the course of the first hour of care. They had really minimal symptoms other than some mild chest discomfort, some dizziness and nausea. And this absolutely helped triage patients to the right place and get them that care so they could have a good outcome. So that's where serial ECGs can help. And I get asked a lot of times, how often should you repeat them? Totally depends on your system, where you're at, what you're capable of. If you're working a pre-hospital system and it's one-on-one care, sometimes two-on-one care in the back of an ambulance, there's no reason you can't do those every, Q 5-10 minutes. If you're in a hospital busy system, that might not be realistic to you. So whatever's realistic to capture that, but certainly as reasonable as possible within that 10 to 20 minute window is a great way to do some serial ECGs. And if your patient develops any acute change in symptoms, that is another key indicator that we need to make sure and do serial ECGs. All right, so we're going to switch gears a little bit. We're going to talk about the acute MI or the OMI, STEMI, whatever word you want, in wide complex presentations. So what about when we have a left bundle, or we have a ventricular pacer, or we have PVCs, or anything that doesn't fit that normal criteria? Most of us were taught, especially with left bundles, that it's either old versus new when we're trying to pull up old ECGs. And while that's certainly helpful to review old ECGs, because some people can certainly have some difficult to read ECGs, there's some pretty easy rules that we can apply to abnormal complexes like this to help improve our diagnosis. In fact, I'd almost argue I'd almost prefer new UI because the rules are a little simpler and easier to use. To understand why this is a problem, you have to understand what's going on. So in a normal person, in most leads, your QRS and T waves are concordant, which is kind of counterintuitive because depolarization and repolarization of the myocardium represent opposing charges, right? The depolarization is overtly positive, and then repolarization by default is going to be the opposite charge because you're repolarizing. So really, T waves and QRSs should be discordant in pretty much all cases, yet that's not what we find. And the reason for that is that we depolarize and repolarize in opposite directions in a normal heart. And so that has to do with the permeability of the cells located within the endocardium versus the pericardium, and how quickly they can cycle through. And as one would not expect, the epicardial cells tend to undergo their cardiac cycle quicker and actually start repolarizing sooner. So even though the endocardial cells may have depolarized first, it's the epicardial cells that actually start to repolarize first. And so what you end up with is an inverted vector of repolarization, which results in concordant T waves in most leads. Why that matters is any delay in depolarization, whether it's a bundle branch block or left ventricular hypertrophy or a ventricular pacer rhythm, any of those things that delay, even strain patterns, anything that delays depolarization will cause the T waves often to flip. And when they flip, they take the ST segment with them, and will often drag the ST segment either up or down depending on which way they flipped. In left bundles, because the QRS is negative in V1, V2, V3, you have these deep S waves, you end up with discordant ST elevation that is appropriate and normal for that patient, which confounds our ability to identify anteroseptal STEMI in that group. So now that you understand the relationship of that and how that works, we can then apply those rules and identify abnormal ST variations. And before I even go into it, while I'm here at this slide and you're looking at it and you're listening to this, the easiest thing to just demystify the entire process is that yes, left bundles and ventricular pacers and PVCs have some apparent ST elevation that can occur, but it should never occur. The ST segment should never deviate with the QRS complex in those rhythms. And what that means is that if I'm looking at this ECG right here, and instead of ST elevation in V2 and V3, I see ST depression in V2, V3, that doesn't make sense. That's not accounted for based on the electrical phenomenon that it occurred. We should expect, if my QRS is down in the left bundle and my T wave is up, that I would have some ST elevation. But I should not expect, if I have a downward QRS, that I would have ST depression, and vice versa. If my QRS is up and my T wave were down, or up as well, I should never see ST elevation in that presentation. There's nothing benign or inherent to left bundles that would cause that. That is only caused by a pathological phenomenon associated with a transmural injury pattern. And so that leads us into the Scarbosa criteria. And if you look here, Scarbosa A criteria is here, Scarbosa B criteria is here, and then this is C. So I want to ignore C for a second because there's a little bit of discussion on that. But if you look at A and B criteria, the commonality here is that the ST segment is going with the QRS complex rather than the T wave. And that is abnormal. If I see a presentation like this where the QRS is down and T wave's up, I would expect some ST elevation. There is a limit, which is what Scarbosa C talks about, but it should be going with the T wave. These are abnormal and pathognomonic for that transmural pattern. When we talk about C criteria, it gets a little bit more complicated. All C criteria is saying is that yes, the ST elevation is going with the T wave, but there's a limit that can be considered benign. The initial criteria was 5 millimeters. It was not overly sensitive or specific. In fact, if you had just Scarbosa C criteria, that was not enough in of itself to activate or to be diagnostic for STEMI. And so they modified that criteria. This was the work here was done, I believe, by Dr. Steve Smith out of Minnesota, and who coined the term OMI as well. And if you look here, what they did is they, rather than using overall millimeters, they used a ratio, which just seems to be a commonality when we look at ECGs, right? It's all a ratio to itself. And so rather than looking at overall 5 millimeters, if the ST change that is going with the T wave, which is what we would expect, if it's going greater than 25% the either depth or height of the QRS complex, that is excessively discordant and is diagnostic for acute MI. And so, yes, the ST segment can go with the T wave, but there's a limit, and that limit is 25% the size of the QRS. So if I have a 10 millimeter tall QRS and I have 3 millimeters of ST depression, that's 30%. That ratio is deemed excessively discordant and is concerning. Okay, so let's apply this to some actual ECGs. So we look here, we've got pacer spikes and a wide QRS. So we have a ventricular paced rhythm. And if we try to apply those rules, we look, is there anywhere where we see the ST segment going with the QRS complex? And if you scan this, you'll see right here and here and here, we see downward pointed QRSs and T waves that are upright. So we have the normal discordant pattern of a downward QRS and upward T wave. However, the ST segment is down as well. So the QRS is down, the ST segment is also down, which doesn't make any sense if what we would expect here is some slight elevation or isoelectric presentation, not the downward QRS and downward ST segment. To give an example of normal, if you look over in the inferior region, we see a downward QRS and a discordant upright T wave. with some ST elevation, and that's your normal presentation to be. While there is some ST elevation, it's appropriately discordant because it's not greater than 25% the depth of the QRS. You only have 1 or 2 millimeters, and this QRS appears to be at least probably 18 to 20 millimeters deep. So this would be positive for Scarbosa B criteria and is an underlying indicative of an underlying LAD occlusion. Okay, so another example, this is one we looked at earlier. This is a 3rd-degree heart block. You have some concerning signs in the anteroseptal region and some concerning inferior changes as well. But the reason I'm highlighting here is if we look at these ectopic beats in the middle, these are PVCs, and lead V3 looks okay. Lead V2 looks a little concerning, but V2 is the obvious one. And what I think is really neat about this is a PVC where if I apply the rule, my QRS is down and my ST segment is down. And so that is Scarbosa B criteria in a PVC. And if you compare it to the underlying rhythm, the MI is presenting more obviously from an ECG standpoint in the PVC than it is in the underlying rhythm. So pretty neat case of applying Scarbosa to a PVC. So here we have a right bundle branch block pattern. Your QRSs are upright in all of the precordials, essentially, which is typical presentation for a right bundle. If we look, we have a upright QRS, downward T wave, but my ST segment is elevated. Even more obvious here. In fact, your T waves have become concordant instead of discordant like we might expect. This is called pseudo-normalization, where you're in abnormal presentations like bundle branch blocks where the T waves may be, the normal is discordant T waves. A flipped T wave in that case makes it look normal where you have concordance. So they turn that pseudo-normalization. So it makes an abnormal rhythm almost look normal. And on top of that, you have the upright QRS with the obvious ST elevation. So this one's pretty obvious. This is an anteroseptal STEMI overlaid on a right bundle branch block. And a similar case here, patient's bradycardic, but otherwise pretty much the same presentation. We have a right bundle RSR prime pattern in V1, upright QRS complexes throughout the entire precordial leads, and you have ST elevation following the QRS in those leads. So this is another anteroseptal STEMI overlaid on a right bundle. So this is taken on a physio, so the pacer spikes are what those arrows are denoting there. So we have a wide QRS and a V-paced rhythm. If we apply those rules, we look over question 1, is the QRS and ST segment deviating in the same direction? If you look at ABL, that is the case. We have a downward QRS with ST depression. And since we're looking at ABL, we're going to scan down at the inferior, and we have a downward QRS, upright T waves, and the ST segment's going with the T wave, so we would think that's normal. But to recall that Scarbosa C criteria, it's only supposed to deviate up no more than 25% the depth of the QRS complex. And so you can see here the ST elevation is as high as the QRS is deep. So rather than a 25% ratio, it's essentially a 1-to-1 ratio. So this would be deemed excessively discordant. So this is an inferior STEMI applying Scarbosa B and C criteria rules, in this case, to a paced rhythm. You can see an RCA occlusion manifest on this V-paced rhythm, which is in fact what this patient did have. So I want to stick with the abnormal presentations, but I'm going to switch gears from the Scarbosa and the wide to talk about this unique presentation you see here. So to give you, I'm going to throw you into a case and then we'll discuss it. So this is a middle-aged male patient, has history of angina, had a bout of chest pressure radiating to his left arm, seemed worse than normal, and then drove into the ER, comes in, and you see that you get him into triage. The patient chest pain has resolved. This is your initial ECG. When you look at it, you'll see that abnormal T wave presentation that is popping up in V3 and V4, V3 especially. So this presentation, when you see this ECG in the presence of a patient with ACS-like symptoms that have resolved prior to the ECG or remarkably reduced symptoms, that is indicative of Wellens sign. So that pattern right there is something that you want to remember. And the scary part about this one is that it presents when the patient is pain-free. So why does that happen? What is Wellens? Why would we see this? So the reason that they need to have a dramatic reduction in symptoms or be pain-free is that Wellens is an example of reperfusion to the myocardium. So what happened underneath is this patient had 100% LAD occlusion or a near complete occlusion, and then something happened and a little bit of blood flow was restored to the myocardium. Had you taken an ECG during the time when the chest pain arose, you would have most likely seen ST elevation and a classic anterior STEMI pattern. But due to the reperfusion of the myocardium, you're getting this T-wave pattern here. And you can think of it almost like a TIA is to a stroke, except maybe a little bit more severe in this case for this patient's at high risk of reocclusion. And so this is definitely somebody that we want to get to a PCI facility to make sure that we can catch them prior to reocclusion and going back into that anterior STEMI pattern. So what to look for? There's actually two types. There's type A and type B. Type A is the biphasic T-wave pattern that goes up and then down. That's the key hallmark to it. There are other biphasic patterns that go down and then up. Hypokalemia is an example. Digoxin is another example. The hallmark to type A Wellens is that it goes up and then down. In type B, you just have complete inversion of the T-wave. It should be deep and symmetric, just as you see there. And again, the diagnostic is tied to their presentation. So this must be an ACS patient with resolution or dramatic reduction in symptoms at the time the ECG is taken. If not, then we need to keep investigating and see what we're missing. But that is the hallmark for Wellens. So if we look here, we see that type A pattern goes up and then down with no ST elevation, up and then down in V3 as well. And then you have some type B over here. You've got that complete inversion of the T wave. In this example, we have complete inversion. So this is type B across the board. You'll see similar types of patterns like this in other things. So you can see this in rare cases with patients with raised intracranial pressure, with certain strain patterns. It's important it needs to be tied to the patient presentation. So this presentation of ECG in a patient with resolution with ACS symptoms that have resolved abruptly or dramatically reduced, that is very concerning. That's a reperfusion pattern and indicative of Wellens. If this was a patient that had suffered a significant head injury, and you saw these T waves, that would make these cerebral T waves, and I would be more concerned about increased intracranial pressure at that point. Obviously, the patient has to match the ECG to make the diagnosis. And so then I just kind of wanted to end on a scenario, so we're just tying it all together. So I threw an ECG up here and going to put you into a case, and then we're going to kind of just work through the diagnosis. Feel free to pause it if you want to look at it more closely as I run through this. So you have a 64-year-old male presenting in distress. Patient's anxious and restless on your stretcher. Skin is pale, cool, clammy. They look ill, kind of altered, and you have some crappy vital signs. So blood pressure is hypotensive, patient's slightly bradycardic. And so when we look over the ECG, prior to taking it, you would have, this is a patient that you would have expected to see like either VTAC or a massive STEMI, and you look over and you see this pattern here. So when we look, hopefully your eyes go to right here, we see these tall, symmetric T waves, and then the concurrent ST depression. And so what do we think about that? And if you kind of run through everything we talked about today, it's got a couple of the OMI checklist items, but this is the presentation for the De Winter's T-wave pattern, which is tall symmetric T waves, right? Those rocket ship looking T waves in the anterolateral region with concurrent ST depression. This is an early LAD occlusion. If we let this sit, you're going to end up seeing those ST segments go from depressed to elevated and a more classic anterior pattern. So this is a patient we caught early, and if we can get them to PCI, they have a good chance, or a better chance than they would have if we waited, to have a good outcome. All right, I appreciate you watching. If you have any questions, feel free to reach out.